Continuing the series of investigation in male infertility, I, Dr. Sunil Eshwar, infertility specialist, laparoscopic surgeon at IKEA Fertility, Bangalore. Let's talk about the semen parameters which we look at and what is the implication of this. Not all the parameters which we look into the semen has any significance, but there are few parameters which are really significant when it comes to the outcome of pregnancy. First thing which we look is what is called as volume, means how much ml of semen should be there. Generally we say it should be around 1.5 ml is a minimum cutoff when we call it as low volume. So what if it is less than 1 ml you can't conceive? No, it's not like that. Even if it is less than 1 ml, but then other parameters are normal, you could still conceive, but just to define the volume as to be low, that's a criteria taken as a 1.5 ml. Otherwise what you can see is a kind of a 1 teaspoon of semen is 1.5 ml of measurement. Now next value is what we call it as liquefaction. Semen when ejaculated is in a semi-solid or in a very thick viscous state. So this has to become liquidy, because this viscous state is which carrying the semen or the sperms within it. When it becomes liquid, it allows the sperms to migrate out of this thick viscous. So the whole system is, once the ejaculation happens inside the vagina, the thick viscous state is required so that the sperms are maintained inside the vagina, and when it becomes liquid, it allows the sperms through its channels to enter the cervix and the uterus. If it doesn't liquefy, the sperms doesn't have the ability to get out of this viscous state, then the sperms are most likely going to die within the vagina and not migrate into the cervix or the uterus. So pregnancy is a little bit unlikely to happen. So we call this thing as a liquefaction time. Generally anything less than 60 minutes of liquefaction time is considered normal. So if it is happening early, it is fine. There is no limit to tell that okay, it happened very quickly, so it is an abnormal. We only define it as a delayed liquefaction if the semen liquefaction doesn't happen within 60 minutes. So that is another factor which can lead to difficulty in conceiving. Next parameter which we look at is the total count of sperms. So in 1 ml of semen, there should be minimum of 15 to 16 million count. That's the count defined by WHO, and if you look at the years back, what was the definition? Previously they said it is around 20 million, there is some confusion about 25 million. So these numbers have been changing, and now over a period of time we come down to around 15-16 million as a low sperm count. There is also, when there is too much of count is also there, but we do not take that as very significant value. Okay. And the next parameter of importance is motility. If you understand, after the semen which is deposited inside the vagina, the sperms need to get into the cervix, into the uterus, then into the fallopian tube, where the oocyte is sitting ready for the sperms to come and fertilize them. So this whole journey, if you compare to that size of the sperm to that of the journey the sperm makes, is like you starting from Kanyakumari and trying to reach Srinagar. Right, so it's that's the amount of distance the sperms need to travel, mind you, and in a very stipulated time. So if the motility of the sperms are less, it will not be able to make this journey quick and fast. So the motility, again there is a different percentages which we assign. In a normal sperm count, if the motility is rapid progressive motility or the slow progressive motility, all motility put together more than or equal to 50% is good. Rapid progressive motility of 32% is also very good analysis. Next most important parameter is the morphology, structure. The sperm has a different divisions as head, tail, neck kind of thing, which we define when we look at under a high definition microscope. Each plays a different role. The head has all the genetic material within it, whereas tail and the neck assist in the forward progression from the vagina to that of where the egg is sitting ready for the fertilization. Now If there is any defect in this structure, like either the head defect, neck defect, or in the tail defect, the sperm may not be able to do the function which is necessary. That is, only one function the sperm has, that is to go and fertilize the egg which is sitting inside the tube. So if the head is abnormal, if the neck is abnormal, or the tail is abnormal, it may not be able to go up to the the egg and convince it for fertilization. So these are few parameters which we look at it. Then some of the extra parameters we also look at is there any increased white blood cells which could mean that there is some kind of an infection. Not necessarily the infection is in the testis. Generally the infection is outside the testis. So it could be in seminal vesicle, or in the prostate, or in the vas deferens, or it's just that the penile infection also can be there which can be represented as a white cells. Then there are some advanced testing which we do. We do only the advanced testing if it is necessary. In sense, we find any of these parameters to be abnormal, then only we call this as a call for the advanced testing. Now, how do we categorize this? So as I said, if the volume is low, we say low volume. If it is delayed liquefaction, we say delayed liquefaction. Now, if the motility is less, we call them as astenospermia. If the morphology and the structure is defective, we call it as teratospermia. If the count is also low, we call it as oligospermia. Most of the time, we find what is called as oligoastenoteratospermia, that is low count with low motility and structural abnormality. So many a times we come across with the reports which are very staggering, and sometimes it puts us in a doubt whether that semen analysis is right or wrong. Count is absolutely normal, and then we say that the motility is very low. This is quite often seen because most of the time this thing happens if there is any acute insult like infection, fever, or any stress which has happened 1 or 2 months back. Sometimes we come across the reports which brings in doubts about the authenticity of the report. So it is never possible that the semen count is very low and motility is absolutely normal and morphology is absolutely normal. It can be in the borderline range, but we have seen reports telling that semen count only around 5-6 million, but morphology is 60% normal, 80% normal. So that is really not a way the semen really, or the function of the semen happens. If the count is low, generally the morphology is also less or defective, and motility is also somewhat affected. Until unless you have collected a semen where it is spilled out, you have spilled out, and then only the the later part of the semen is collected. The forepart of the semen, are the first pre-ejaculate or the ejaculate which comes in the first part, are the ones which contains the dense and good number of sperms. If you have just collected the last part, then it happens. And again, something which we come across is most of the time the morphology is reported as 60%, 70%, 80%, which rarely happens. So when we get this kind of a report, we generally rerun it, because we know that normal as a in the humankind, so much of changes over the period has happened that the semen parameters have actually plummeted down, and WHO itself says the morphology of anything more than 4% is normal. So when we are coming down to tell that 4% is normal, and we say you have 80% normal morphology, well, that is a superhuman, or probably we can call that person as a superman, or it is a defective report. So this is how we analyze the reports, and we will talk about how much significance you need to put on a report, and if you get these reports, how do we react and what is the future course of action. Thank you.